This conference will now be recorded.
Okay, am I audible? Please. నేను 65 మంది వచ్చారు. స్టార్ట్ చేసేస్తాను. Okay, we'll be starting the class. ఫ్యాన్ వేసేసి ఆపేసినట్టున్నారే. Okay, today we'll be talking about pilonidal diseases. In 7th semester, probably you have already exposed to this topic. We'll be talking on briefly about pilonidal diseases. So we will talk about the introduction, incidence, pathology, presentation, management, exercise, etc. So the first one is in 1833 by Herbert Mayo. Coined the term was done by Hodges. Okay, Latin pilonidal means nest of hairs. Okay. So Latin means nest of hairs, pilonidal. Most commonly, the disease is seen in men, and it came into prominence during the Second World War because the people who are driving the jeeps for a very long duration of time suffered with this. Though in the old times, the jeeps were not as comfortable as now. We used to have hard seats. The seats used to be hard and these things. So more friction used to be there. So they have had many very commonly had disease, jeep driver's disease. That's why it's called as a jeep disease. So incidence, rare. See, the maximum incidence is after puberty to 25 years. Rarely it is seen up to age of 40 to 45. 40 to 45 in males. Can be seen in females also if you have very hairy and especially in the natal cleft area, if we have a lot of hair, this is very common. More common in Caucasians or white-skinned people than Asians and Africans because it's more in the growth characteristics. So majority the problem is sedentary occupation, positive family history, obesity. This is one of the most important reasons nowadays is obesity. Because more obesity, more friction in the perinatal cleft area, and more chances of pilonidal disease. So majority of the cases, if you ask the history properly, one they'll give any history of trauma is there, maybe there is a history of prior trauma or local irritation, they'll give both, maybe irritation due to constant rubbing of the skin. Okay, so these things are present in people up to 34%. So history is, this is important. So origin of pilonidal sinus, how it comes, symptomatology and everything. It's a bit complex, but not even today. There are few differences in understanding the pathophysiology of this. Some say it is a congenital sinus which is present previously in the perinatal cleft area, which becomes lodging site for the hair follicles, hair and other things, and cause the disease. Some say the hair broken ends of hair due to the friction in the area will go through the skin and form the pilonidal disease. So there are various theories. Okay, so the common part is that hair, friction, and infection. These three are common in all theories. So broken hair will go. Yeah, someone is asking something, they can ask in the chat box. Your voice is not really good, audible to me, so you can ask it in the chat box, I'll answer. So broken hair, friction and infection, this is very common cause in all the three all the theories. So broken end of hair will, due to the friction, will puncture into the skin in the natal cleft, and tuft of hairs enter the pit, and there it starts infection. Then it will cause pilonidal cyst and cyst structures causing pilonidal sinus. So as I said, hair follicles are source of pilonidal sinus. This is again contradictory. Some say yes, some say no. The reason being, majority of the pilonidal cysts or sinuses, hair follicles are not seen. So some people suggest that this is wrong. Okay. So more recent work on specimens wide excision has shown that pits penetrating into the dermis are distended with keratin and debris, but not all arose in hair follicles. Okay, not all arose in hair follicles. So, as I said before, the hair entry is the primary event. What kind of hair enters? The broken end of hair. So once they are growing, the friction causes the hair to break, and one of the broken end, which is sharp, will penetrate the skin up to the dermis. However, evidence suggests that enlargement of follicles precedes hair gaining access at the operation and at operation. Hair is found only in half cases. See, what happens is once hair start puncturing the skin, that place, due to some unknown factors, there will see small, but definitely there is no 100% guarantee that you will be seeing uh, the skin, hair within these pits. Okay. So the hair acts as a foreign body, then it causes inflammation. Prolonged inflammation causes the root cause of pilonidal disease. So prolonged inflammation, there will be granulation tissue is formed, sinus perfect. The distension of the obstructions. Okay, from the skin for the hair to hair, ruptured hair develops into sinuses and everything. So deep abscess cavity with surrounding moist conditions, abundant bacteria, hair, debris, friction, recurrent infection, which will cause chronic pilonidal abscess and sinus pain and discharge. Operating the butt so repeatedly, if this keeps on happening, the chronic draining, multiple draining tracts or single draining tracts will ఓకే వచ్చింది 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 సరే చేసేదే ఉంది ఆపేయడం ఇంకా ఆపేద్దాం. Okay, so this is how it will be. So majority of the time there will be a intermittent discharge with some presence of chronic pain because of there is ongoing inflammation, and there will be swelling, duration will be there. Okay, local edema. And duration will be there. Tough. So if you carefully see, so this will be like a branching tuft, just like a tree, it branches, keeps on branching. Okay, so this is the sinus will be opening here, it will be there, but while it is going there, multiple branches are formed and openings are formed here, 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 and everywhere. So if you see, there is an abscess right now, active abscess going on with multiple tracts in this part. Okay, so it is a complex, then recurrent pilonidals in the sinuses. Okay. So management. So how do you manage these cases? The diagnosis is very straightforward with only one differential diagnosis. Like fistula and nano is one differential diagnosis. The diagnosis treatment is very straightforward. So you have to treat the infection, you have to remove the tract, you have to do everything to prevent the recurrence. So this is a very simplest thing. So presentation, at the time of presentation, how is the patient, his main aims of treatment, these things should be taken into consideration, because this is a very distressing symptom, because patient cannot sit properly, cannot work properly, and cannot disclose it also because of privacy issues and these things. Okay, there is a lot of discomfort for the patient. So you have to treat accordingly, you have to relieve him of the pain, and always keep that recurrence should be kept in the minimal. Okay, you should enable the patient to resume social and normal working activities. That should be the goal of the treatment. So asymptomatic pilonidal diseases, the first and foremost is local hygiene and depilation of the hair, and after that surgery is the definitive treatment in any pilonidal diseases. Okay, so it is a not a known what proportion of the disease develops asymptomatic diseases. Like patient will have small sinus, pilonidal sinus, but tomorrow if you neglect it, the patient will develop a pilonidal cyst, abscess, and chronic this thing. So at the earliest we do a surgery, that will be the better. Okay, the risks and discomfort of electrosurgery is also there. The patients usually will not come until they will have, the patient develops some kind of symptoms. Okay, so conservative management will be done in an acute abscess case, in which IND with abscess, drainage of abscess with antibiotics. So this is the first thing that you have to do. So the pain will reduce, local inflammation will reduce, and everything will reduce. Okay. Next, once the symptoms resolve, then you have to go for the excision of the tract. So if, yeah, that is how it has to be done. Okay, so other things are also there. Phenol injection, not at all done. Phenol, you know, it is an irritant, inflammatory, so it will irritate and close the tract. High recurrence rate needs frequent repetition, so it is not done. So operative management, majority of the cases are for incision and drainage, excision and healing by secondary intention, excision with secondary primary closure, excision with reconstructive flap techniques. Okay, incision and drainage, acute abscess, and all other three are depending upon the patient choices. Okay, incision makes an elliptical incision in the abscess just off the midline, so you remove abscess along with granulation tissue. If you can identify the tract, it will also be removed. then you have to do curettage. I hope you people all know what curettage means. There will be some scoop like curette will be there, and with that we scoop the tissue of the wound, so that if there is any chronic granulation tissue is there, it will be removed. Okay, so this is one way of doing. This is actually one of the best ways of doing surgery. Okay, even though healing is takes time, this is one of the best results. Gives one of the best results. Okay, some not sometimes many people will develop pilonidal disease even after surgery. The reason being, the predisposing factors will be always there: friction, hair, these kinds of things. Okay, if you are very careful, recurrence rate will be reduced to about 15%. So you at the time of surgery, you have always have to look for secondary pits. Like there can be multiple secondary pits will also be present. You have to look for them and you have to remove them also. Next is healing by secondary intention. Here we open the wound, we leave it like that to allow the granulation tissue to come from below outwards and close the wound. This is, as I said before, has long duration of complete recovery, but one of the lowest recurrence rates of pilonidal diseases. This is because even if you close the skin primarily, some tissue might be left behind, and it can again be a source of infection. But once you do it by secondary intention, the granulation tissue will push out all of the things from out inside to outside. So the chance of recurrence will be, that is how it will be reduced. Okay, but duration recovery to work is a bit prolonged in a case of excision and secondary healing by secondary intention. So advantage is lower recurrence rate. Average healing is up to 2 months. Despite there is a role for wide excision in those with extensive chronic disease. So if it is more granulation tissue, more tracks, then uh, primary closure is very risky. Okay, so in these cases, wide excision is better, or at least flaps will be modified or standard excision. Skin edges are not sutured but brought closer. So that what happens, I will show you in a diagram. So suppose this much amount of tissue has been. So how to reduce the size of the wound? See, we all know that skin epithelium comes from periphery to the center. We all know. No? This is a second year concept. So if the epithelium has to come, the wound is normal. Fill up the granulation tissue, then epithelium comes. This, but what happens in this marsupialization? This skin part will be removed. This part undermined will be removed under the skin. So it will be made like something like a bowl, if you see. Then after that, this part will be brought down, of skin will be brought down, and this part will be brought down to the wound surface. Like on the back, it will be sacrum. So the recurrence rate is never decided about by the antibiotics. The reason being, as I said, it is in the perianal region. The bacteria will always be there in that region, and you can't avoid the bacteria. So then there are other procedures like modified BASCOM's procedure is come. So here you see the tracks, no? So we will remove the tracks, we will make a lateral skin incision and mobilize the skin medially. So here it will be a fresh wound, but this midline wound will be closed with primary intention. This one being non-infected will heal very fast. Okay, so this is one modified BASCOM. Advantages and disadvantages will also be there. It can be done only for a small lesion, simple sinuses, like these kinds of things. Excision with reconstructive procedures are like plastics. So this KARYDAKIS, what we are telling this one only. KARYDAKIS is marsupialization kind of thing. Okay, this is KARYDAKIS flap. You can see small tissue is removed behind the skin and these things are brought down. Okay, this is an ellipse with skin excision and marsupialization kind of technique, because of which healing will be faster. So excision and flap, you all know, there will be some rotational flaps will be made so that immediate primary closure is brought. But again, the risks of infection, failure of the rotational flap, recurrence of fistula, these all these things will be there. Okay, and then again it is a KARYDAKIS flap with which we will close the wound. Okay, midline wound will be closed. So this is a rotation flap. It is called a LIMBERG flap. Okay, there are other flaps like V-wave flap, gluteus maximum flap, Z plastic flap, etc. Post-operatively, the first and foremost thing what you have to do is packing, pressure packing, so that a lot of seroma doesn't collection, prevention of seroma. Then wound should be packed, preventing premature closure of wound edges. Then hair and debris that should be removed daily, almost daily. Weekly shaving or depilatory agents should be used, and you should never allow any hair to settle in the granulation. If you allow granulation tissue to have any hair, again recurrence of disease will start. Early signs, wound prompt treatment with broad spectrum antibiotics for 2 weeks. So if and then any other thing is needed, absolutely no use. So recurrence can have one or more other sinuses during the first surgery. Okay, late recurrence, surgical technique failure, inability to remove the complete tract, etc., or if any hair follicles get trapped during the recovery period, etc. In summary, you know, pilonidal sinus is very cumbersome, uh, embarrassment for the patient. Because they cannot go to work. It's not that it is very, because of social they can't go, because if there is soakage in the back they can't show to other people. Na? So that is the thing. Okay. So this is surgery is the main treatment. Standard principles you have to remove: repeated depilation of natal cleft, removal of hair and any debris, keeping the wound edges separated using appropriate dressing. So recent advances, platelet-derived growth factors, VAC. This is one of the best things nowadays. If you keep VAC, the wound will close at a very rapid pace. Okay, this will make the wound granulate fast, and even it can dry up the wound fast also. Can be done even on outpatient basis. Even patient can take it to home. So this is about pilonidal disease. If anyone have a doubt, please ask me. I'll clarify your doubts. If you don't have any doubts, we will end the class. Okay, so we will end the class.